Hey, this is Dr. Scott Worden, the TOS guy, live from Sunnyvale, California. We're experiencing a great summer here. I hope you are all doing well. Today, we have a special guest, Dr. Sam Ferris from the Mayo Clinic in Jacksonville. Hi, Sam.
Hey, Scott. Thank you for
How are
having
you?
me.
Well, we're really glad to have you. We've met really only recently over the past couple of months, and you have developed a really comprehensive TOS program in Jacksonville. And I'd like you to share that with people. But first, you're a vascular surgeon. Would you share with people a little bit about your education and how you got here?
Yes, thank you, Scott. And thank you again for having me. So I followed the typical traditional general surgery training after I finished my medical school. And I did that initially at Mayo Clinic in Rochester, Minnesota. And then followed that by extra training with general surgery in multiple different places, including New York and Georgia. After that, I did surgical critical care fellowship at Johns Hopkins, and then vascular surgery fellowship at University of Tennessee. After I finished, came back to Mayo Clinic, this time in Jacksonville rather than being in Rochester. And as you mentioned, the weather is much nicer here in Florida. So that was an easy decision to make. And I've been practicing for now 15 years. I joined the practice at Mayo Clinic in Jacksonville. My older partner has actually special interest in thoracic outlet syndrome. And he was basically evaluating patient. We had a diagnosis pathway for that. And I also became interested in that. And, we did some cases together, given, his seniority. And I learned a lot from him. Afterward, I've been doing evaluating this patient and doing this surgery on my own, and I felt over time that actually I evolved with the disease or the condition, I would say, and probably we'll touch on this in a little bit. But I feel TOS, continue to be a enigma to a certain extent. And I actually enjoy my evolution through that learning process, learning from patient actually as well, as much as also learning from my colleagues and other specialists.
That's great. First of all, I agree with you about the evolution of our thoughts on TOS, and I definitely want to get into that. I did want to ask you, who was your senior partner who was doing TOS? I wasn't aware that you had somebody you had worked under for a while.
Yeah, so it was that Dr. Andy Oldenburg.
Okay.
Yes, he retired back in 2018, but he was at Mayo Clinic for a long time, probably since 1995 or even before, actually.
How long had he been doing TOS?
I think since he started. So, he also was trained at Mayo Rochester, and Mayo Rochester back then had multiple very notable classic vascular surgeon who contributed to the thoracic outlet syndrome literature. And in fact, actually, when I did my internship there, also in Rochester, I got opportunity to work with some of them, and it was something Mayo is known for. All the graduates from the vascular surgery program and fellowship there. Basically, to a certain extent, had interest in this.
Didn't Adson work at the Mayo Clinic?
Probably, yes.
Yeah, he was one of the original guys in this country working on scalene anticus syndrome or cervical rib syndrome.
Mm-hmm.
And he would do anterior scaleotomies where you would just detach the anterior scalene muscle from the first rib. And a lot of the patients did well, and that's because you had in back the cervical rib and in front the scalene insertion. So you gave the brachial plexus a degree of freedom. But he did have a significant number of recurrences, which of course, without imaging at the time, he also came up with absence sign, which is a sign of the blood flow in the radial artery when you move the patient's neck and arm and you try to get that artery to narrow. Assuming if the artery is narrow, then the then the nerves are also compressed. It's a very logical approach. So your interest in TOS, did you have any knowledge of it or interest in it before you worked with your mentor?
Actually, very limited. I mean, I had, when I was an intern, again, general surgery, as probably you remember from your training, you're like a deer in a headlight, right? So even I participated in some of the thoracic outlet first rib resection as a first year. I don't remember being able to see anything or even understand what we're doing. I just thought it's fascinating in terms of surgery, and that's pretty much it. After I did my training with my fellowship, that allowed me also to do a few first resection, but really the main interest happened after joining my colleagues here at Mayo Clinic Jacksonville.
Yeah, I personally, I don't remember anything on TOS in medical school or in 2 residencies that I did. It's weird. Some people have some training in it, and I'm glad you did. And other people go through all their training and never see much about it and just have to learn later by reading in a textbook.
Yeah, I would say it's very limited. Even for me before, it was very limited, interaction.
Well, I'm glad you picked up the mantle, and now you have your own program you've developed and refined at Mayo Clinic, and maybe you can share with us, with our viewers, how that's organized and how that multidisciplinary approach works for patients with TOS.
Yeah, absolutely. That's great segue to the whole program tonight. And I would emphasize, TOS, now that I know more and understand more, it's not a one-person show by no means. So it's definitely a multidisciplinary program. It relies on every single person involved in the process. So for convenience, I take the lead. What sometimes can come with more responsibilities, but in reality, every single person is actually equally important. At some point, learning from mistakes over the years, you realize that, and better than me, when it comes to that the diagnosis and precision of diagnosis is a key element. And we talked about Addison signs or Rus or all the other signs. I think they were helpful historically at some point, and they just basically give us the idea that you need some kind of maneuverable thing to work with. Diagnostic tools now we have, especially with the high level ones, they basically take that idea, but it's a way higher level where you can precisely pinpoint certain aspect, and that's cannot happen. I'm not a radiologist. I don't have specialties in any of MRI or advanced CT angiogram or other imaging. So definitely you have to rely on a radiology team who knows also this diagnosis. They see it a lot frequently. We have neurologists who also have a special interest in this, physical medicine and rehabilitation, pain management, regional anesthesia. Then you have the physical therapist who also have to have interest in this. So, more specialized. And some people who are interested in shoulder, brachial plexus, also expert. So you have to add all that team, and I'm just mentioning a few here. We're I would say lucky that we have all that under one roof, so we can process that in a little bit more efficient fashion rather than have a scattered basically care. But that's definitely the key, is how to get to the right diagnosis as much as possible, and then from there, I think this actually allows us also to understand that you're not going to have like one treatment. So you're not going to have a one approach or one pathway. The pathway is going to be individualized to patient presentation, patient needs, and also patient goals. So even if 2 patients present same way, one of them is an athlete and one of them is a different stage in life and function, you have to tailor your treatment based on that, because it's not going to be it's just going to be pain control or pain improvement, but in addition also function at the end and performance, and everything else comes with it. So more like a goal directed. That's the way I see it, and this is where I just realized with time that I'm always learning. There's always something new to learn and figure out all these intricate details.
Which is, by the way, another value of a multidisciplinary team, because a physical therapist is going to tell you something that, or at least for me,
Yes.
physical therapists have their own specialization and they say things I would never think of. And it turns out to be very valuable when I'm understanding, interpreting an MRI, for example.
No, 100%. And every time I talk with my radiology colleagues or physical therapist, PM&R, physical medicine and rehabilitation, I just realize how much blind spots I have. How much I had even more blind spot in the past, right? Like seeing kind of like, black and white, and it's never black and white, especially with TOS.
Right.
It's really very, I would say, uh, it's very satisfying in terms of learning, and I think this is a great time for TOS.
I agree. It's a great time. We're learning a lot. We have more contacts around the country. People like you and I have connected over a patient, and I learn a lot from hearing about a patient's course. I'll just give an example for our viewers. We had a patient recently who we sent to you, and her husband works with her closely to try to get this young woman better. And they were just gave you just the most glowing reviews about how organized your program was. Everything was set up. They went appointment to appointment, had all the tests prepared before they ever saw you. They felt, number one, that it was very comprehensive, that it was multi-specialist, and that you had all this data available for you by the time you assessed them. So in our first experience, I think the patients are very, very satisfied that they're getting as thorough a workup as is possible. So kudos, your team seems really professional. Now, the other part about being humbled and learning new stuff, I don't know if you've ever heard of the Dunning-Kruger effect, but it's where people start out when they first learn something. They're like, oh, this isn't so hard. Astrophysics, how hard could it be? And then the people who've been doing it for 20 years who become experts, they realize those blind spots and they realize the subtleties and complexities, and it makes them far more humble, which is how you sound right now. But that's the sign of somebody who's really a serious learner. So
yeah, absolutely. And there's fun comes with that learning, like this ongoing curiosity, and the satisfaction comes with it when you feel like you're helping, our patient.
I tell people on this channel often about Pete, P-E-E-T, who wrote the first paper using the term thoracic outlet syndrome. He had taken all these papers written ahead of time and said, well, look, there's endless anatomic variations in the thoracic outlet, and there's all these different causes of this syndrome that different authors have written about. So let's give it this one name and put everything together. Yes. And I feel like now, as we talk about surgical techniques, because there are several different surgical techniques, we talk about imaging, we talk about treatment with hydrodissection or with muscle blocks, we are starting to separate that out again into all these different causes. So the treatment can be better. We're getting hopefully better at triaging patients to surgery or conservative care. And then within each group, hopefully each treatment modality is more effective. I don't know if you find that yourself.
Absolutely, 100%. And I would like also to add that someone wise told me once, don't confuse the map with the territory. And I found it actually truly, accurate in this situation where, in the medical field, as a human, generally speaking, and especially in the medical field, we like, to classify things, just make things more organized, make it easier to understand, easier to study. But really, life and nature and anatomy doesn't respect the classification we make. And sometimes it's time to re-update this classification, the understanding. The muscles don't feel themselves being separate. They're all like one unit. They work dynamically, and to look at anatomy being this static image in a linear fashion, that's the worst thing we can do in this situation. So I think people when they started understanding thoracic outlet syndrome, they did the best they can, and they did us, great favor with everything they accomplished. But as we understand more and knowing how dynamic, the body in general, especially this area, to put everything in one box, okay, it's useful just to help us give it a name, so we can to help with other aspects from the medical business standpoint. But in reality, it does not help the patient. The more you look intricately into different muscles, and not just each muscle, but also the interaction between them. Okay, and that's the part where I find it's almost endless to pin down to exact point.
I think that's a great point. I can tell you, since reading MRIs, I'm realizing it's not like an anatomy textbook. There's not just one separate anterior scalene muscle and a completely separate middle scalene muscle. There's endless variations we see in patients.
Yeah, and I tell my residents, my trainees, the human body does not care what the anatomy book says. So this is the map, right? This is the map. You can look at it. It's helpful to a certain extent, but at some point it gets you to a point. But then you need to be in real life. Real life is what you see there, and that's basically the mystery, the science, and the art all combined.
Right. Yeah. Sometimes, with some frequency, I will read a paper that has a sign, a radiologic sign, or some explanation for a disease, and I never knew it before, and it's always been there. That's the territory. That's nature. But now someone points it out, and you finally recognize it. So I try to keep that in mind. There are plenty of things going on. I may or may not see them right now, but it's like unwrapping little presents. Find them as you go along. So let me ask you a few things that are more technical. What kind of approach or approaches do you take in the patients that you do go to surgery with?
So I would describe our group being very conservative. So we always find excuse not to perform surgery as much as possible. If I have to be very practical and describe what kind of like criteria, I would say, generally speaking, basically the diagnosis has to be as precise as possible. The symptoms has to be significant enough. Patient already failed what we call conservative therapy, and we can go over that if you would like. And then I would say, patient goals also has to be understood and attainable. Okay, so when we have all these combination, I think that would be a good patient for surgery. And we can go more in detail in terms of like how what's the diagnosis. But I would say in general, we try always to match what we see on the imaging, provocative tests, the clinical presentation, good physical exam, match all that with basically patient presentation and patient complaint, what they complain about, what's the main reason would bring them here, and basically we'll go from there.
So when you do a physical exam on a patient who's gone through the program and you think has TOS, what are the provocative tests that you find most useful and reproducible?
So honestly, and I'm just being honest with you, I can't rely on physical exam alone. I think physical exam to me, and we have all these historical signs, we document them all, for the sake of completion. But they just kind of like, to me, initial signs of maybe there's something there. What I really look for initially is a thorough evaluation from physical medicine and rehabilitation and peripheral neurology, where they already exhausted, long list of diagnoses, and they feel comfortable that they can't pin it down to something, and now everyone thinking maybe TOS. So our protocol is an exclusion, but also an inclusion, type of some sort. When we get to that point, now they see me, of course, all the historical signs, Adson, East, Russ, they're all going to be documented there. I specifically feel it reassures me feeling actually tenderness to palpation along the pathway of the anterior scaling muscle and also medial to the border of the PIC minor. I don't see them as separate entities. I think it's the whole area. Some patients mention flares, which is an interesting concept. Like, this is, things I picked up as I saw more patient. And my understanding before of TOS was more like, 1 or a 0. So flares kind of like throw me off. And this is where I feel you get better understanding when you feel that tenderness along the pathway of the anterior scalene, certain specific point. And I mentioned the medial border of the PIC minor. So I feel these, yeah.
So you're looking both supraclavicular and infraclavicular.
Correct.
And
yes.
Okay.
Evaluate the shoulder in general, scapula retraction, certain maneuvers. The main thing actually, as we just mentioned, there's no one size fits all, and different patients show up with different presentations. So I asked them, what triggers your symptoms, what bothers you the most, in what position, and we try to get to that point without affecting them too much, which is also something I found with as I practiced more, I saw more patient. I remember that one patient, I was just doing my typical exam, just gently actually doing my palpation, and it triggered something, and she was crying and couldn't stop, and that's actually shocked me. I didn't anticipate that and had no intention to hurt the patient, but that's how you have spectrum and variability from one patient to the other. So basically, I try to see. Let's get to the as realistic as possible to what patient complain about on a daily life. And I think a lot of time when we get to imaging, we missed. Some patients say why you get TUS missed. Well, because it's rarely these tests are done in a way that matches patient posture or position that normally trigger the symptoms, and I found that's actually that's interesting when we spoke about your special MRA, the TOS one that you do, because it tries to cover these aspects. Like routine MRI misses all the time if you do it routinely.
Right. But that's just like a routine physical neuroexamination.
Mm-hmm.
Misses the signs. You have to do provocative tests, and you have to know what you're looking for, as you described.
Mm-hmm.
The test that I do has modified over years because of people like you, Sam. I ask questions and I learn things and find out you might need certain questions answered. So that's another value of a multidisciplinary team, that you can do your job better because the clinical doc knows better than you as the radiologist what questions need to be answered. So I've learned through that. So you have, if I heard correctly, you have neurologists on your team that evaluate each patient. Is that correct?
Yes, more like peripheral neurology.
Okay. Do they or you utilize EMGs and nerve conduction velocities a lot?
So it's part of our protocol. So every patient has to have EMG. Yes.
And do you find those useful either in inclusion or exclusion?
So I think, to me, the main role for EMG is for, finding other reason for patient complaint that are not TUS related. So I don't use it to say patient has TUS. And even sometimes, rarely actually, EMG reads comes back as consistent with TUS, and I'm always surprised. And I don't even find myself taking it seriously, honestly. So it's more like for excluding the common, reason for typical presentations. So more like a cervical source for patient complaint, carpal tunnel, cubital tunnel syndrome, other processes. I find it can be helpful. TUS, since again, we're talking about being a really a very, very wide spectrum, especially when we talk about neurogenic TUS. a lot of time it's more like an irritation. That's the way I describe it to my patient than an actual nerve injury. Okay, so the irritation really that leaves signal on EMG, and if I see a signal of what to me indicate more severe or profound injury, I'm more concerned now. I'm thinking I need to find out what else beside, even if there's TOS component, there's maybe other component here, and that will be crucial instead of guiding the patient into surgery that can help them, but not 100%, or may
Are
not help.
are you referring to a multiple crush situation?
Yeah, that brachial plexus, disorder of some sort.
Like an inflammatory, like Parsonage Turner?
Yes, that like that, and also sometimes trauma related,
Right.
triggered TOS after trauma. So sometimes it's not going to be just like one component. So there's maybe other shoulder related issues there that need to be addressed and taken into consideration, and not just being looked at, as just in a linear fashion.
Glad you brought that up. Thank you. So do you also have people evaluate shoulders for like labral tear or rotator cuff tear?
Yes.
How often do you find that a patient who you clinically suspected has TOS, in fact, has shoulder pathology? Is that common?
I think it's more common than what I realized initially. Now I have the benefit of being in a tertiary center, so it's rarely that I get patient off the bat who have like TOS, who question having TOS. So most of the time they already went and been on Odyssey to figure out what's going on. So
Right.
probably locally they already saw a shoulder specialist. They saw the different orthopedics, specialized people, hand surgeons. Uh, so they usually show up with a lot of imaging, a lot of testing, documentation that shoulder is an issue, is not an issue. But even with that, you still be surprised that because how tricky this is, it can be something that everyone else missed, of course, including us.
So you review this medical history very carefully with that in mind.
Yeah, I review it, and also I really rely on my other, experts,
Right, your
right?
teammates.
Physical medicine, because I can tell you, I'm not going to be able to diagnose a very complex shoulder problem, or like if it's like some kind of trapezius muscle related issues, or so this is where the blind spot, my blind spot, which I know now for sure that exists, I get it covered by other people who are more experienced than me and smarter than me.
I hear you. I'm glad that I know people who can solve a lot of these issues because it's over my head. So that's really great extra service for the patients. They come in, as you mentioned, some of them have had extensive workup by their primary care doc and other docs in the community. And after a while, as the size of their medical record grows, the next couple doctors they see just won't have the time or the wherewithal to put it all together.
Mm-hmm.
So it's a really good added value of your team.
Mm-hmm. Absolutely.
So what about, do you do any muscle blocks like scalene blocks or pec minor blocks? And do you
Yes.
find them useful?
So we do both, and also that's part of the protocol. Again, we talked about the analogy of TOS being like a very historically being a rigid box where we put all these complex stuff in one just to simplify things. But in reality, that's not what happens, right? So you're going to have overlap, and the overlap probably is more common than the non-overlap. And I would like to know how much the standard thoracic outlet, which in my mind as a vascular surgeon, it means the only the thoracic outlet region. So that would be anterior scalene muscle, the first rib, middle scalene, and a little bit of the clavicle subclavius area. But then if you go outside that area a little bit further externally, now you're in the PIC minor region. So that's not how vascular surgeon thinks of thoracic outlet, right? So this is like your out. But really, it's you're talking about like a couple of inches away. It's not that that really further out, and that can be also involved, or that can be a triggering factor that led to the involvement of the more medial thoracic outlet region. So in order to tease out which is what, I think you need to do both. So I actually personally never operate without doing a block, and it's typically done by a very specific team. It's the same team who basically perform the anterior scaling block, and there's another team who perform the PIC minor. That's kind of like their special interest. So they can typically accommodate patient in a very short notice. We try to be sensitive to patient coming from far away. When you try to condensate imaging and everything patient needs in a very tight schedule as much as possible. So I don't remember the last time, which probably a long time ago, where I did surgery without the scaling block. Now the exception would be if patient comes with a venous thoracic outlet syndrome or arterial thoracic outlet syndrome, because different story.
Yep. Those are different animals.
Different animals, and patient comes a little bit more urgent, more severe symptoms, so they have to be addressed in a more urgent fashion. The block doesn't add much value, but these are actually a small percentage, right? Because the majority are either neurogenic TOS or mixed, and the mixed are not mixed enough. The mixed meaning neurogenic and vascular component, but not the catastrophic urgent vascular component.
Right, and in my practice, we almost never see venous TOS as a primary diagnosis, and I don't remember a single case of arterial TOS. That's usually a surgical emergency. So gotcha. And the diagnostic challenge is really neurogenic form. The other ones are easy. So you always do an anterior scalene block before you go to surgery. That's what you said?
Correct.
And PEC minor blocks are done by a different team in your program?
Yeah. So this is more, I would say, specialist interest. It just usually grows organically at Mayo Clinic, and we're very collegial, so there's no territorial issues at all. So typically, historically, that's how it happened. Anterior scaling is done by our regional anesthesia specialist, Dr. Clendenin. And the PIC minor happens it's kind of like split between two groups, pain medicine, who have also PM&R interest, and also Dr. Troyer from physical medicine and rehabilitation, who has specific interest and training in doing PIC minor block.
That's great. That's really helpful for patients.
Yes.
These things happen in hospitals politically and historically. There's a group of docs who only do the left shoulder, and a different group of docs who only do the right shoulder. And while we understand it from being in hospitals, patients just want to get treated. So let's go back to the scaling block. If that is a negative result, you will reconsider surgery. Is that correct?
Yeah. So I definitely be very, very hesitant to perform surgery. So that's why I kind of like the insistence on the same person doing the block, because we commented earlier about reproducibility. So that's one thing. The block is done in a very, very standardized fashion. There's even actually a video taken for every single patient before and after, with I would say adjunct measurement. Very detailed measurement, even including actually vasculature, velocities, and stuff, which is it's not typically related to the block, but more like showing how much, to simplify it for patient, I usually say how much relaxation happened to the anterior scalene, which allows change in the velocities in the vessels in the region. So of course, but the main judge would be how patient feels, right? So how they feel after, that's the main thing. Everything else is adjunct. We collect it for other reason, but then we want the patient is the final judge. How much they improved? What's the percentage? And with some other details. So when that same person is reproducing the same thing over and over and over, if he gets me a negative result or no response, I'm really very hesitant, and I have to look into things. Is there something else going on? For example, if there's a fixed band, okay, that you cannot see on CAT scan, where the MRI comes helpful, right? And somehow we missed it. So no matter how good you are with the block of the muscle, you still have anatomical obstruction. That's how I think in my mind to make sense of what happened. So in this case, maybe there's something like this, but I'm not going to take someone to surgery just because this maybe. I would say, it happens extremely rarely where a patient will see me. We get to a point where I'm not going to recommend surgery, and we convince them to do physical therapy, work on other things, figure out other things, and then they come back 2 years later, okay, and they already went through odyssey of trying to find out what's going on, and they come back, and basically the discussion completely changes and becomes, okay, we can do surgery as diagnostic tool, which is very extreme. Okay, and I tell the patient, I was like, I've done enough of these surgeries that I'm not worried about the surgery, but you're the patient, and I don't give percentages complication, even that they are less than 1% or whatever. But when they happen to the specific person, they're not 1% or less anymore. They're 100%. So that basically would be my concern, and over the last maybe 5-6 years, I remember one patient we ended up doing this, and you can't tell if they improved or not, but they wanna just try it.
So if patients don't respond to the directed physical therapy and the other measures, then with enough time, you'll reconsider the fact that they had a negative scaling block and you still want to go to surgery.
So I actually reconsider everything, reassess. And that's also a key in this situation, and also in recurrent situation or incomplete improvement. We reassess, we start rethinking the whole process again. What did we miss? So probably when they come back, which is going to be again, a year plus period, probably I'm going to do the block again, especially given that this is a dynamic issue. Maybe things change. Maybe now you can get a response which you missed first time or something like that.
And when you do the scaling blocks, I presume you're using lidocaine and ultrasound guidance? Okay.
Correct. Yes.
This is a theoretical question because I don't see anything in the literature that confirms this. Why do you think a positive response to an anterior scaling block indicates a better response at surgery? What's the cause of the relief?
So I can tell you, the real answer, I don't exactly know.
No, nobody does. It's a trick question. I'm just like, what do you think?
So the way I explain to patient that the muscle is relaxed at this point, being paralyzed, and the thoracic outlet region is now decompressed, at least partially. There's more room for the structures within the thoracic outlet area. That's including the nerves, and maybe that what gives the sense of relief. Anatomically, that's hard to prove, right? Because really, the plexus is not as adjacent to the scaling muscle as the vasculature. It's close, but it's not that close to explain that, significant improvement sometimes,
Right.
So, but in theory, that's how it looks. Maybe the area relaxed in general. I see it more like I would say, how the body holistically normally work. If the main muscle relaxes, right? So maybe the tension, that the workload on other muscles to try to compensate for the failure of the scaling muscle maybe that overall also relaxed, and maybe that you have wider opening than what you anticipate. It's just not just one muscle, being affected, but actually totality of a group of muscles, and maybe that's what at the end of the day helps the plexus, relieve it a little bit. So maybe, but
It would be interesting to do an
yes,
MRI study before and after scaling
oh,
blocks and see the
absolutely,
position of the first rib and the position of the scapula, position of the cervical spine, but nobody's done that to the best of my knowledge. So
yes.
thank you for discussing the hypothetical.
Yes.
With a pec minor block, I'm presuming the same thing, lidocaine under ultrasound guidance.
Correct.
And so when you do a pec minor block, do you use the same criteria, like you're hesitant to go to surgery if that's a negative result?
So no, so for the big minor, the criteria is much more relaxed. It's more, I would say, practically. I want to know how much the big minor is involved. If I get good evidence of the big minor involvement, so when and the decision is to go with surgery, then I would like to do everything at once. So patient does not require 2 surgeries. Especially that most of these patients, their preference is to go transaxillary, so incision under the armpit, and through that incision you can do the whole thing through one incision. So that's why it would be the preference. But if they are PIC minor positive, anterior scaling positive, I'm thinking more about just PIC minor release only. If
they're scaling block positive as well, then you just try pec minor autonomy. Is that what you said?
No. So if the anterior scaling is negative,
okay,
if they feel no improvement there, but the PIC minor is positive, they improved with the PIC minor, so maybe only the PIC minor is what need to be released. And see that more common in actually athletes with overhead type of sport or activities. Okay, a lot of times they can be PIC minor syndrome related issue that's mistakenly being labeled as traditional thoracic outlet neurogenic,
right?
Where typical vascular surgeon, they will just do the rib removal and scalonectomy. So in this case, if you can miss the PIC minor and you do the surgery and they still don't improve completely. So that's kind of like a caveat there, to kind of like distinguish based on the injection. So I feel the injections are extremely important in terms of temporary relief, allow you more diagnostic precision. Okay, and if you'd like, also we can talk about this, which is they can give you a jump start. Since we're talking about being conservative, avoid surgery as much as possible, they can give you a jump start into a robust physical therapy that otherwise would fail.
And in that case, you might use Botox. Am I correct?
Yes. In that case, we'll do Botox. I don't do it myself. That also would be our pain medicine team and physical medicine rehabilitation. They would do that.
So to clarify for our viewers, you get a pec minor block that's strongly positive. Patient has a lot of relief, and you give them the option of doing an ultrasound guided Botox injection, which lasts a lot longer, and it enables them to do directed physical therapy more easily.
Correct.
Got it.
Yes.
That's very good.
Yeah, so, I feel like it helps with you have a vicious cycle they trapped in, and it breaks the vicious cycle for temporarily. This is where you get the window of opportunity to help them with very precise physical therapy.
That's a great description. So it's a vicious cycle because the muscles get too tight, and then the muscles put the shoulder in a disadvantageous position. You get more compression, the muscles get tighter, and it gets worse and worse, and you're breaking that. And
yeah, you break also, that. Yeah.
Yeah, go on. Sorry.
No, so just more details in terms of like when that breaks, it takes a little bit for the Botox to kick in. So that time, I like to imagine it being, you need to allow this muscle to relax for a little bit before you now also put all the work back load on it. And typically kind of like a week to 2 weeks. Then after that, they will have that directed physical therapy.
Great, that's really helpful. You also mentioned pec minor syndrome as outside the box of traditional TOS. I find that a
which is
really
now, now to me, it's not necessarily outside. It's part of a bigger group of we just need to widen the box a little bit.
the spectrum of TOS, all the different anatomic variations and all the different compression, tension points. Yep, cool. When you do surgery now, when on the patients you do go to surgery with, you mentioned the transaxillary approach. Do you do any other approach as well, or is that your preferred one?
So I do all of them. My preferred one is the transaxillary for neurogenic specifically, and also for venous TOS. I feel like aesthetically, patient prefer it. Relatively speaking, it's a small incision. When you go transaxillary, really you don't split any muscles. You basically, because you go between the big major and latissimus, and you create a subcutaneous tunnel until you get to the target area. So I feel like that's less disruptive post-operatively, at least theoretically. And it allows maximum removal of the rib. So if you take your time, coming from underneath everything, so you can get underneath the clavicle at the front and all the way back to the transverse process in the back.
So you remove the entire rib, head, neck, the anterior osteochondral part. You remove everything.
So I would say as much as possible. So a lot of patients, everything. There's smaller group where there's a lot of I would say inflammatory process happening, where I just make sure I do good compression. So with movement, different position of the arm, I make sure that the plexus is completely freed. It's not in any contact with any bony structure.
Got it. That's helpful. What do you think, if you've read much or you have colleagues you've worked with at all who do either robotic surgery or rib sparing surgery, any experience with that at all?
So I'm glad you asked about this. So I personally don't do robotic first rib resection currently. Our group, however, is working on basically doing a single port robot first rib. So we're in the process of developing that, and we did some experiments. We proved that it works. We have some publication in the work right now. We wanted to do it the right way, so we want that to happen through FDA approval. It's called IDE, so it's an investigational device exception in order to, full patient safety and everything comes with that. Difference between this robot first rib resection and the robotic first rib that now exists, that you don't have to go through the chest cavity. So
you're going transaxillary?
Go transaxillary, yes. You go transaxillary, so it's mimic the open surgery, and you have enough space to work with. Again, we already did a couple of cases in cadaver. We showed it works. Very short period of time. Patient will be positioned supine, opposite to the open surgery position. There's minimum arm retraction during surgery. There's no need for lifting and anything problematic that comes with that, and you don't have to go through the pleural cavity as well.
Got it. So for the viewers, transaxillary means in the armpit underneath, and there's a small tunnel, right, Sam? It's a limited viewing area. You have to be very good at your anatomy because it's a long, narrow tunnel. So the robotic can do that. You don't have to raise the arm as much and put the plexus under tension. You don't have to go through the space around the lung. You can work and see more clearly because your eye is basically inside with the robot.
Correct.
So that's very cool. I'm curious to see how that will turn out.
Yes.
And then have you read much or any experience with colleagues on rib sparing scalenectomy?
So I have limited experience with this because I actually never performed only scalenectomy. I see patients who come to me with scalenectomy being done, but still symptomatic. I don't have a strong opinion against it. I think it's a matter of diagnosis. So people who end up with splenectomy and they still have symptoms, I would think probably diagnosis was not very accurate in terms of what's involved in their in creating their symptoms. So they still, in my mind, belong to the thoracic outlet family, but you need to make sure that the splenectomy is the only involved structure in what causing the symptoms, which probably would be very rare. Also, that would be my assumption. So it's not hard, it's not easy to prove it. So that's why I'm not a big fan of splenectomy alone. And in case if that's what you need to do, probably just then do Botox injection instead.
Yeah, the papers that are out, because this is fascinating to me, on rib sparing surgery, there's no imaging ahead of time. So from my point of view, I'd like to see these things. It's possible that they have the nerves going through the scalenes, or they have a narrowed scalene triangle, and that they don't have narrowing between the collarbone and the first rib. And that may be why it's successful, just to spare the rib resection. But we don't
Yes.
know. And
Yeah,
like you keep repeating, quite honestly, it's great, is that there's variance in these patients, and we need to select the right patient for the right procedure. And so
Yes.
we can, as a community, we can be better at that.
Yeah, and
Which-
I think if this paper, if the group or the cohort of patient they use, probably they were very good at selecting, and that's really what we need. So I'll commend them on being able to select the right patient, and maybe for that right patient, splenectomy alone would be the right thing to do.
That's a good point. The criteria we use to make the diagnosis, as you said, there's some nebulous qualities to this. You need a big team and a lot of tests. Some of it's exclusion, some of it's inclusion. So when you read papers with outcomes, one of the first things I read is how they selected patients. When also from my point of view, when I read outcomes, we're not great. We're good. I think there's a lot of really dedicated people working, but our results could be better. And I suspect that's because the group of patients that enter these studies is heterogeneous. Any thoughts on that?
No, I think this is an ongoing problem. How to measure outcomes, how to be objective with measuring outcomes, especially with a very subjective phenomena. So you try your best to be as objective as possible. There is patient agreed upon patient outcomes in the thoracic outlet literature that we try to follow as much as possible. They involve patient survey and basically try to assess pain improvement and also the functionality of the patient. They're not by any means perfect enough. And the other thing is there's a lot of variability in the literature of how long you follow these patients. So it's not easy
Right.
to do adequate follow-up. Our group, for example, we tried to do that. We had we decided to study patient prospectively over 2 times period, and we had over 100 patients. We only could collect information from 28.
Oh,
At this point where you can't keep bugging the patient, even that we try to call them, but I would say I take it as a good sign, because probably since they don't have a problem, they don't worry about it anymore, right? So
right. So the better outcomes are being hidden.
yeah, so but that's unfortunately that's not how you do research, right? So you need to get
Right.
these outcomes. It's not hard. It's not easy to collect it. Yes.
I'm going to switch gears here because I know we have lots of questions from viewers. So let's take a few questions.
Absolutely.
All right, from Aaron Bruschi. Can you expand on the role of focused body work and massage therapy in resolving TOS? Also, what are you doing with patients after first rib resection who continue to show symptoms?
Okay, that's a very good question. So I have first to profess that I'm not a physical therapist nor a physical medicine and rehabilitation expert. But I would say just the general focus would be improve posturing, work on the scapula, retraction, basically strengthening other muscle groups, doing stretching as well. So any exercises that allow the scaling muscle, anterior scaling muscle, to stretch, at least in theory. There's a lot of good work done with that, and plenty of exercises that shows it's tailored specifically toward neurogenic thoracic outlet, so that can be helpful. Same thing with the PIC minor, so that definitely can help. In terms of massage therapy, I would be very careful. How's the massage is done? So if someone knows how to stretch the muscle, you may get a little bit temporary relief, but it's not an actual therapy. It's more just for like temporary relief. It's not helping you in terms of strengthening muscles, or first stretching the muscle that need to be stretched and then strengthening the muscle that need to be strengthened. It's not going to do that with the massage.
And you have people on your team who deal with this if this patient wants to come see you or talk to your team?
Yes. So, or we at least can guide them. So not everyone can have the physical therapy necessarily at Mayo itself site with limited, but we normally guide them of where to go to. In terms of the second part of the question of if patient continue to have symptoms, as I mentioned earlier, we go to I would say point zero. We reassess. We start from the beginning. We missed something. Okay. So it's either incomplete decompression, or if it's complete decompression, there's another point of compression or a problem, right? And so we try to figure out what we missed exactly there.
Excellent. Thank you for the question. Judy D. Amarillo. I have all this. Judy, I'll just tell you ahead of time, we don't answer specific medical cases, but we'll approach this generally. I have all the signs and symptoms of TOS, but normal on a brachial plexus MRI. I had a Marcaine nerve block with temporary relief for about 6 to 8 hours. My physical therapist has shockwave and EMMT. Will that help? I'll just tell you the first sentence. Brachial plexus MRIs, in my experience, that are done around the country are just looking for the plexus itself to be intrinsically abnormal. And I think that's very rare, even in patients with clear TOS. It's really a study, when it's done right, in my opinion, of all the structures around the brachial plexus, of the pathway of the brachial plexus, of the anatomy that that particular patient has, and of what happens when you move your arms. So in my opinion, a normal brachial plexus MRI does not rule out TOS. And the rest, let me hand to Dr. Faris.
Yes, so I couldn't agree more. So it's a positive thing that Marcaine nerve block helped temporarily. 6 to 8 hours is actually perfect expected time for the improvement. So I would say this is probably on the pathway of what we expect of someone we're working with to show thoracic outlet syndrome. In terms of the shockwave and EMMT, theoretically it makes sense. I would say equivalent to that would be the hydrostatic dissection. It's kind of like the same concept, where you think there's some facial problem or some adhesions and you break them loose, and maybe that will allow more space for the nerves. I don't have personal experience with this. I'll be cautious about prescribing that for a patient. If it helps for this specific patient, as long as there's no harm, maybe it's worth try for them.
So nerve gliding, we're talking about nerve gliding. The nerves in your body, everybody, do glide as you move your limbs. And if they get fibrosed or tied down with scar tissue, that can create problems. I think that's what Sam was talking about. Also, I'd caution this patient, a nerve block is different than a muscle block, for all what Dr. Faris has described in detail about PEC minor block and a scalene block. Those are within the muscles. If you go to see a dentist and you get a nerve block, the nerve is going to go numb. So by itself, it's not the same as a muscle block.
Yes,
and
thank you for mentioning this.
Thank you for the question. All right, Briar Visser. I'm terrible at pronouncing usernames, so forgive me if I get it wrong. Sorry if I missed this in the talk. I have neurogenic TOS, and I've gradually started to have symptoms of a vascular component. What level of symptoms warrants further evaluation?
So excellent question. So I would say more extreme type of vascular component. sudden swelling of the arm, discoloration, whatever changed in color, the arm basically being pale, cold, there's loss of pulse. So this is really very urgent situations and require right away immediate evaluations. Other component of vascular changes, I would say, they need a specialist to take a look and be thorough.
Yep. If you have a vascular component like an artery that's blocked or a blood clot in a vein, go to your ER.
Mm-hmm.
Don't waste time. Thank you for the question. All right, 22 Tate. I am also curious about the mixed patients you see and what symptoms of venous TOS they exhibit.
Yeah, so most of the venous TOS I personally see, just to keep things short, are more severe. They show up with clot. And that means DVT, deep vein thrombosis. They have significant swelling of the arm, heaviness. Sometimes can be even worse. They develop pulmonary embolism, so they have difficulty breathing. So it's very, very extreme. If it's less than that, if it's just some vein popping up or vague feeling of heaviness but no obvious swelling, I would still go through thorough evaluation and take our time to figure out what's going on.
Yeah, I'll add in that some patients get venous congestion where the blood flow doesn't return from the arm to the chest. And while it's not an outright blood clot, it can cause neuropathy and discomfort. McCleary syndrome is one I've mentioned before. Same person wrote in, Sam, for example, if one's hand goes white quickly upon raising one's arm, is that venous TOS, or is it possible for it to be neurogenic?
So it's less likely to be venous TOS, not necessarily zero, but probably it's neither. It can be other etiologies. So there's some other syndrome, Raynaud syndrome, and other vasculitis-related issue, connective tissue disorder that show up like this, especially if they returned also quickly to the normal color, and if there's a triggering factor.
Thank you for the questions. Aldana Music. I had venous TOS, had surgery to remove a massive blood clot in the whole arm, currently on blood thinners and waiting for more diagnostic tests to be done. So again, without specific medical answers. Oh, I started also having numbness and tingling in the forearm and hand. Are there any good specialists in Orange County, Southern California area? Let me take this second part, the pragmatic part. Please reach out to us through our contact us on the website, tosmri.com. We can give you names of specialists, TOS specialists in the Southern California area. And now, Sam, any questions about this or any statements about the massive blood clot?
So I'm glad first that you're doing okay. I mean, that's really, that's a blessing for sure. I would like to add that it sounds like the second half, maybe there's also some neurogenic maybe component as well. I would, beside doing a thorough blood workup to make sure there's no blood inherent reason for clotting, if that is basically confirmed that nothing shows up on the blood work, probably you don't need too many tests, and you need to see a specialist. And Scott, you'll be able to help to figure out, because I think something more need to be done in this case.
Thank you. Yes, that's great. I'm glad you're doing well. That's a little scary, have a big blood clot. Thank you. Next question. Hamsterly. Is it reasonable to expect a scalenectomy, first rib resection, and pec minor release all in the same operation? I think we partially addressed that. And the same person says, of course, if someone has both TOS at the level of the scalenes and at the pec minor level.
Yeah, so I would say, I'll be very, very cautious, right? I'm assuming that the diagnosis is precise and we exhausted all other options. If we know for sure that that's what's going on, yes, it's reasonable to do all at the same time. And probably you don't want to go through two surgeries when you can do them in one. And, the pec minor release, when you added the first rib, really it add maybe like 10 minutes extra to the surgery, max, maybe 5 minutes, 5 to 10 minutes extra. So it's not significant. but assuming this is really what we deal with. So that's my only reservation.
Sam, this brings up a question I forgot to ask before. Do you, when you do a decompression, do you also do neurolysis? And if so, a large extent, a small extent?
So if you go transaxillary, you have limited exposure to the plexus, so you only see the lower portion, and that's the only part that you can do safely the neurolysis. Now, if I think patient need neurolysis, it's a completely different story. So this is when I go supraclavicular from above, because I want to have all components of the plexus addressed and thoroughly neurolysis performed. So that goes also to diagnosis what I think is going on. That's usually typically for more redo. There's something, we're coming back.
Yes.
It's not the first time being there. There's more work need to be done. So this is when neurolysis will be done thoroughly from above.
Great point. Send those patients to me. I can tell you, post-op patients I've seen, one of those complications is this post-op brachial plexopathy.
Yes.
So, and I don't think that's in the literature. Thank you for the question. Devin Patel. Hi, Devin. How would you work up a trauma/structural upper extremity, shoulder, acromioclavicular, sternoclavicular injury, TOS issue for someone who didn't have a specific onset injury? And then the second question, Ehlers-Danlos syndrome, does that change your perspective on, I guess, the diagnosis or type of procedure, or would it limit the number of procedures? So we know Devin, and that's a good, complicated question. So take your time.
Yes. Okay, so I would say, if a patient comes with trauma, okay, and certain aspect also that applies to Ehlers-Danlos syndrome, I'm extremely careful, right? So this is when, to just say it simply, you load the boat. Okay, so we already gonna have a lot of specialists who are gonna weigh in, but now each specialist, in case of trauma injury, with presentation of TOS, we want all of us to be extra careful because there's going to be a lot of overlap. And normally I tell my patient, avoid simpler and straightforward answers. So you come in with a complex situation, don't expect simpler answer for it to be the answers. Actually, you have to run away from simpler answers. So you're not going to have capacity to address that without having a really, truly experienced multidisciplinary team to tease out all the different elements and not to have that assumption that, okay, I'm going to do the surgery, remove the first ribs, connectomy, or routine surgery, and things going to get better. Absolutely not. Ehlers-Danlos, same situation in terms of being extremely careful, being very thorough. And Ehlers-Danlos is different types, so they're not all the same. If they have a vascular Ehlers-Danlos, which is a special category on its own, probably, I would say my chance of doing surgery almost zero. If they have Ehlers-Danlos that's not vascular Ehlers-Danlos, so the other type of hypermobility, it explains why they are more vulnerable for having TOS, and they still have to go through the same protocol. If they check all the points of the protocol, I may offer them surgery. I just, try to be careful during the surgery, extra careful. So I take extra time because the vessels are more fragile, and you don't want to, basically have any I would say extra irritation to the vessels while you're doing the surgery. So I'm careful during the surgery itself, but everything else in terms of workup applies the same, similar to other patients.
Thank you, Devin, for the excellent questions. Judy Amarillo again, thank you so much for educating us with TOS. Some docs don't really have an idea how to deal with it. Thank you for a compliment, Judy. I think thanks go to Dr. Farris for spending time and a lot of effort to help us understand what he does. And also, I can tell you from early reviews, the patients have loved his program so far. It's very organized and very thorough.
Thank you.
Thank you for the compliment, Judy, and we're glad to help. That's it for our questions. So Sam Ferris, I'm going to interrupt for a second here. To all our viewers who are still here, please remember to hit the like button. That helps with the algorithm, and subscribe if you haven't subscribed already, and then hit that little bell and make sure you get a notice when we're going to do our next live stream or YouTube videos. Follow us on Instagram and YouTube as much as possible. Our job is to raise awareness of the existence of the disease and knowledge of the disease for lay people. We spend a lot of time with patients, and we hope that's helpful. Sam, love talking about TOS with you. One more question for you. What's the future of TOS? Where do you see us 10 years from now?
I think it's going to be an evolving journey. We're going to find out how much we didn't know, more and more. It's going to be more multidisciplinary than we even think right now. That's in terms of diagnostic and workup. In terms of therapies, I think it's going to be less invasive, and that makes sense. We're still using our old tools, and I think it's time to evolve. The evolution is part of it can be, mimicking surgery with robotics and endoscopic different tools, but also probably with different kind of chemicals and different blocks with injections and maybe modulator of some sort. Some maybe super ultrasound therapy to break things, and that all going to be allowed with better understanding of what we're dealing with.
You sound very optimistic.
Yes.
We'll be better at diagnosis and better at treatment and less invasive. I like the sound of that.
Yes.
All right. Thanks to all our viewers who spent time with us. We really appreciate it, and we hope to see you for our next talk.
Thank you. Appreciate the opportunity.
Thanks, Sam.